and welcome, Dr. Nall. Thank you so much for joining us today. As you may know, this year marks the 50th anniversary of the United States National Cancer Act of 1971, which re-articulated a global mandate for the NCI that has existed really since the NCI was first established in 1937. This year also marks the 10th anniversary of the creation of a dedicated NCI Center for Global Health. We're using these simultaneous anniversaries as an opportunity to connect with key leaders to speak with them about their views on the current state of global cancer research and control. I've certainly been looking forward to our conversation today, given the important role you have played in advocating for and achieving global cancer health equity throughout your career. You've led important Lancet commissions to draw attention to this topic, and you've also been deeply engaged in these efforts, formerly at Harvard and currently at the University of Miami, where you're a member of the Sylvester Comprehensive Cancer Center and direct the Institute for Advanced Study of the Americas. So welcome again, and thank you for joining us today.
Thank you so much, Dr. Gopal. And I remember the times when Dr. Varmus was thinking about creating this center, this institute within the National Cancer Institute, and it was sort of a dream that we wrote about when we wrote Closing the Cancer Divide. And so to know that it's now a decade of incredibly important work and leadership in global health makes me really very, very happy to be here with you.
Well, thanks so much. I think we'll get started. And if it's all right, I really wanted to start with your own breast cancer diagnosis in 2007, since it's clearly been such an important and public motivating factor in your professional and academic life. I wonder if you could talk a little bit about your own cancer journey and the links between your experience as a cancer patient and your work as a global cancer advocate, researcher, and thought leader.
Of course. So I was diagnosed with breast cancer. It was my first baseline mammogram in a small town, Cuernavaca, Morelos, Mexico, at age 41. No reason to have assumed, no family history that we know of, and yet that was the diagnosis. And we've written a book about this, Beauty Without the Breast, Tómatelo a Pecho in Spanish. And I lived that experience very much with my husband and colleague, Dr. Julio Frank. And we spent a lot of time living the disease and thinking about what it meant to think about the differences between studying or learning about a health system, and in his case, leading a health system, and living a health system using the experience that's so unique and difficult and challenging of having a chronic illness, an NCD, like is the case of breast cancer. And it gave us a really whole new perspective on how to understand what the obstacles and difficulties are for people, particularly in low and middle income countries, in this case, Mexico. You know, I remember waking up after my mastectomy in one of the private hospitals and looking out the window and seeing one of our national institutes and thinking, you know, there's a woman over there who doesn't have the luxury of deciding whether or not she can go through treatment because she can't afford it or she has no one to take care of her children. She's alone facing this. And then I thought, but we're living in a country that at that point had the Seguro Popular, and it had, you know, just covered breast cancer in its catastrophic fund. And I'm looking forward to speaking with you more about that as we go through the rest of the interview.
Yeah, well, I mean, that's such a powerful experience, and, you know, congratulations on your cancer survivorship. I think that's such a, again, testimonial to how much cancer research has achieved even at the individual patient level. I want to follow from this a little bit. I come in part from the HIV world, and it's always been clear to me how important the advocacy community has been in enabling equitable worldwide access to HIV treatment and prevention. I think you alluded to this a little bit in the answer you just gave. I think a similar movement is slowly happening for cancer, but to me, it clearly has not yet happened for cancer with the same intensity and scale as for HIV. And I'd really love to hear your thoughts about whether the power of advocates has been underutilized for achieving global cancer control, and if so, how we might address this going forward.
You know, and I need to answer it in a very particular way. So there's no question that I believe extremely strongly in the voice of cancer, which is almost unique other than, as you mentioned, HIV. But having seeing this in operation and being a health systems researcher more than a cancer specific person and leading a non-governmental organization that is called Tomatelo Pecho and began its work on women's cancers, I had to ask myself, why am I advocating for only one disease and one part of my body or anybody else's body? And it made very little sense, particularly in the context of a country like Mexico, where there were so many health system needs, but also were sort of all interrelated. And so one of the things that I found challenging is to suggest to our community working on advocacy around cancer that you need to advocate not only for yourself, but also for your health system. That if you're only about you, you're not going to have the impact that you should be able to have with that voice that you have, that's given you, that cancer has given you, to be able to move forward. It's been a bit of a hard sell, but from where I am now, and now at the head of a new Lancet Commission on Cancer and Health Systems, the opportunities to be able to learn, to evoke change, and I'll give some examples that I thought of a little bit later, I think are really huge. But the message I have to say is, don't advocate just for yourself or one part of your body, because we need much stronger health systems. And you're going to, we very much hope, live a long life as someone who is in a process of cancer survivorship. And you're going to face all sorts of other illnesses and challenges, and you want to be able to react to those as well.
Yeah, I mean, that's such a powerful link that you've made between the individual patient journey and the health system in which that journey operates. I want to kind of extend that a little bit. You're an economist, and much of your research occupies the policy and health systems domains, as you just have alluded to, which I think is very different in some respects from my worldview as a medical oncologist. Both perspectives are important and highly complementary, but I wonder if you could kind of extend what you were just saying and articulate why we really have to be focused on policies and systems for global cancer control, in addition to oncologists' understandable focus on specific tumor mutations and how these might be targeted.
Well, there's no question in my mind, Dr. Wood, that we need both. And you mentioned HIV, and exactly what we don't want is that experience of a parallel health system that we know didn't work a decade and a half or more ago. We've been talking a lot about a diagonal approach to health system strengthening, which thinks about both the vertical disease specific and the horizontal platforms that strengthen health systems and how those can come together. And I think cancer, again, is what my colleague, Mary Gospodarowicz, and co-chair of that commission, says is like the exercise machine for health systems, because we can figure things out in ways that are important for cancer and important for all other diseases. I have to give sort of just two examples. One, thinking really from the patient perspective, and this is not the responsibility of the NGO or the oncologist to fix, but catastrophic and impoverishing health expenditures is something that worries every patient and their family, right? But the job to fix that is the job of a health system, because we know that the worst way to finance healthcare is with out-of-pocket spending at the point where you're in desperate need, ill, and have to figure out how to pay for care or abandon care under any circumstance. So it's the job of the health system to be able to figure out a good financial protection model that offers that to all, not only cancer patients. And we saw that in the Seguro Popular in Mexico. But I was also thinking, how could I tell you what cancer has done to strengthen health system from the Mexico perspective? And it's the Seguro Popular, which, as some people know, ended up covering, before it was closed down, very sadly last year, over 15 million Mexicans, and that included many cancers. And it changed the world that cancer patients we're living in because of this financial protection. But a little known story is that when the Seguro Popular was starting out in 2004, there wasn't enough money for the catastrophic illness fund. And a very difficult choice had to be made about what disease to start with. And the choice that was made with a visionary perspective of the group was acute lymphoblastic leukemia in children, because there was a problem with adherence to treatment, because we knew there was such an opportunity to have children survive, because we could strengthen health systems. the bottom line is when we brought that in and people, including Congress, saw this coverage for kids, they bought into the entire health reform. And so it was acute lymphoblastic leukemia in children that made that system run.
Yeah, I mean, it's hard not to note how so much of the health system strengthening work that you've been doing is equally applicable in the United States, especially these days. It's really remarkable, to achieve that kind of scale by focusing perhaps even on a single disease. I do want to talk a little bit about your work, which has been largely focused in Latin America. And I often think Latin America perhaps sometimes doesn't get the attention it deserves. I think in part, I mean, I have my own hypotheses about these. I'd be curious to hear yours. English, I think in many countries is not the primary language of scientific and clinical discourse. Many of the countries are middle income countries, and I think have this dilemma of having too much, but not quite enough resources relative to low and high income countries respectively. I wonder if you could comment on what you see as some of the key strengths and opportunities for global cancer research and control in Latin America specifically.
And I think Dr. Gold, you're right on about this. And we've seen some countries in Latin America and the Caribbean now, at least before COVID, become high income countries. And then they're not eligible for almost anything, including in the US research system, which is a huge challenge because they are, in fact, still living the issues of low and middle income countries. Now, we could talk about how many parts of the United States are really also a low and middle income country as well. But to bridge to what you said about Latin America and linking it to this idea of the United States, I think that this is a region from which so much can be learned and so much can be done. So first of all, this is one of the most inequitable group of countries in the world, and they stand out as such. But on the other hand, it's also a group of countries where a lot of investment has been made in human resources for health. You find top hospitals for cancer throughout the region, that can compete with any of the best hospitals in any high income country around the world. And at the same time, you find people who don't speak English, Spanish, or any of the languages that we're typically more familiar with. These are from indigenous communities that are coming into the health system with cancer. And that's a whole new kind of a challenge. So in our region, you see this whole spectrum from the best quality care and very wealthy individuals to people with very little access, yet already experiencing not only the diseases of poverty, but with epidemiologic transition, the diseases that we're so concerned about en masse related to chronic and non-communicable diseases. So there's a huge opportunity, I think, to be able to understand all sorts of different pieces and how they fit together in a continuum of care and in complex systems that can really inform our understanding in places like the United States as well.
That's terrific. I mean, disparities, I think, in a global context, health systems in a global context, I mean, these are things that we're thinking a great deal about at the Center for Global Health, and it's really great to hear you kind of validate those interests, and we hope to move forward some really important programs addressing those issues. I feel it's almost obligatory now to speak a little bit about COVID. We've avoided mentioning that, I think, until now in the interview, but I'm really curious about your thoughts, where you think COVID, what it might mean for your work in Latin America or for cancer control in Latin America more broadly going forward.
Right. And first, I'm incredibly worried about what I'm seeing as a tsunami of cancer. The data that we're seeing from Mexico about diagnoses make me pretty certain that we're going to see much more and later detection than we saw before COVID. And things were not good, obviously, before COVID. The majority of patients who think about breast cancer were detected in stage 3, 4. But we are seeing in the data, so 25 to 40% less diagnosed cases, people interacting with the health system with cancers than we did pre-COVID. So that's a huge problem. But on the side that I see as with tremendous potential, sometimes I like to call it like an economics of hope, is that it would have taken us decades anywhere in the world, not only in Latin America, to be able to get telemedicine and teleoncology financed. Right? It used to be unusual to think How did St. Jude's do those tumor boards that included Tegucigalpa, Honduras? And how did they fund them and pay for these? And Dana-Farber with Rwanda. But now we really have this integrated as part of the system. Regulators have accepted it. Insurance has typically accepted it. And so we have this huge opportunity to be able to harness the potential of communication to do what we're doing now on this interview, but in the context of cancer. And I think this is incredibly important because one of the most serious barriers that I would face in doing work in cancer in Latin America was on the supply side, because I couldn't get the oncologists to speak to the primary care physicians or nurses or health promoters who were often interacting with their patients when they were back, in their homes. It was difficult for them to do that. They didn't have time to do it, but now there's sort of no excuse. I think that will tremendously strengthen health systems on the supply side, and hopefully make it much easier, to get past some of those, let's call them demand side barriers, and just focus on those, the issues like machismo, lack of information, and all those other pieces that we need to get at in order to ensure that patients are actually coming forward and our health system is welcoming them and helping them through this disease.
Yeah, I mean, I think COVID has revealed such inequity, but as you articulated, also provided some glimpses of how we might really substantively address some of those inequities going forward if we can capitalize on some of the opportunities that have been revealed to us. I think we probably need to start winding it down. I have been asking everyone in these conversations. Again, it's the 10th anniversary of the Center for Global Health, as we spoke about at the opening of this conversation. And I want to ask you if you have any advice for us as we enter our second decade.
I don't know if it's advice so much as hope, hope in what you can all do. I thinking about this, felt that it was really incumbent on me to mention the global pain divide. We did a Lancet commission on access to palliative care and pain relief. And while this is, providing palliative care is by no means instead of cancer treatment and early diagnosis and the whole continuum, we know that all over the world, we have this huge lack of access to palliative care and pain relief. We have 50% poorest in our world with basically 1% of access to opioid medicines. And it's the kind of global health problem that you want to have, because it's not an expensive one to solve, but it can really change the degree of suffering that so many cancer patients and others have in our world. But it's also, I think, such another example of health system strengthening, because if we figure it out, particularly on the regulatory side, for cancer, it will work for so many other patients who are in need. And this was my second thought for the center, is that you have this unique opportunity to do this work, to think about strengthening health systems as well as cancer. And that is really unique in this world. There are very few places in cancer that were born out of the idea that we could do something on global health. And so I think it's incumbent on the center to do what it was set up to do. It's a huge, tall order, but there are ways that if the US, someone in the US, a base in the United States is doing this, it will reverberate throughout the world. And I think, close all sorts of divides, certainly close divides in cancer.
Well, thanks very much for that advice. I mean, I'm sure that we will draw on you repeatedly for advice as we move forward, and probably should start to kind of end it there. I really want to thank you again, Dr. Nall, for sharing your thoughts with us today in this global cancer conversation. And thank you for your inspirational and truly visionary global health leadership. Take care and see you soon.
Thank you for all you're doing, Dr. Gopal.
U.S. Department of Health and Human Services, National Institutes of Health, National Cancer Institute, cancer.gov, 1-800-4CANCER.